the third lecture from Ercan Bal, and he's going to talk about prevention of non-union and proximal junction kyphosis. Please. Yes, we can see it.
First of all, I would like to thank I would like to thank the organizing committee for giving me to speak here. Today we will talk about a subject that is common concern for all of us spine surgeons. I cannot move my. Yeah. Spinal surgeons and architects are similar, however, with a small difference. Spinal surgeons do not have the chance to create any structures. They mostly build their work on existing structures. PGK is identified as a deformity which developed due to increased stress on the upper instrumented vertebra in patients who have undergone posterior spinal fusion. Glattis et al. Defined Glattis for Glattis et al., PGK is a cop angle between the UIV and two vertebrae above it, 10 degree or above in adult spinal deformity. Helgeson et al. Described in adolescent idiopathic scoliosis for proximal junctional kyphosis. He says cop angle between the UAV and the vertebra above it, 15 degree or above. And another authors described the PGK in adult spinal deformity populations. Proximal junctional failure, which is considered a more severe from PGK, at the risk of neurologic deficits, in addition to increasing deformity and increasing pain. The phenomenon has been well used to refer to as Topping-Off syndrome, proximal junctional fracture, proximal junctional acute collapse. Nowadays, we say PGF is a progressive form of the PGK, including UIV or UIV plus 1 vertebral fractures, subluxation between UIV and UIV plus 1, fixation failure, disruption of the posterior osteoligamentous complex, neurological deficit might require revision surgery for proximal extension of the fusion. And for Yagi et al., PGF as symptomatic PGK require any type of surgery. Austin says acute PGF as PGF of 15 degree or more with UIV or UIV plus 1 fracture, failure of UIV fixation or need for extension of instrumentation with 6 months after index surgery. General incidence of PGK in pediatric and adult patients has been estimated to be in range of 0 and 55%. Revision surgery for PGK is 10%. Early onset scoliosis has been stated to be the subgroup within the highest prevalence, and this prevalence was noted to be inversely related to age. Cutoff for PGA cutoff for PG proximal junctional angle 20 degree or more for the SRS self-image, significant difference. Kim et al. Reported that pain is more common in patients with PGK than in those without it. The angle of PGK is directly proportional to pain and inversely proportional to functional. While patients with PGK may be asymptomatic initially, Hart et al. Approximately half of patients who develop acute PGF may require revision surgery within 6 months after their index surgery. We have some risk factors where we can collect the risk factors for PGK 3 heading. One of these is patient-related variables, balance and related variables, and surgical variables. In severe disc degeneration, low bone quality, age, and body mass index, previous trauma, is the patient-related variables changes for PGK. In several this degeneration, there is a risk of developing spinal instability. Low bone quality has also been considered as a risk factor for PGK due to decreased in resistance to the stress in UAV. Some authors believe that the risk of PGK increases with age due to reasons, degeneration in the spine, osteoporosis, and muscle atrophy. Especially age is important for early onset scoliosis for PGF, PGK risk factor. Relation between body mass index and PGK has not been clarified. Previous trauma etiology has also been reported as a risk factor for PGK. This is a case operated for lumbar degenerative disease. Lumbar degenerative disease. This patient we operated several times for PGK, Ross fractures, and later because this patient has osteoporosis, smokers, and is obese because this is the non-Indian factor for the patients. And another risk factors is balanced and related variables. Preoperative sagittal alignment might also affect the occurrence of the post-operative PGK. Post-operative correction is important for PGK. Overcorrection of kyphosis, overcorrection of the lumbar lordosis is important for PGK and PGF. We have some surgical variables. Risk factors for PGK. For example, large paraspinal muscle dissection in the UAV, disruption of posterior ligamentous complex, posterior ligamentous complex damage is the surgical variable risk factors. Combine anterior and posterior approaches, another risk factor. Rigid construction has also been reported to be a risk factor for PGK, and using pedicle scripts in UIV maybe would be a risk factor for PGK. Maybe we can use the hook and smarter transition for protect the PGK. Chrome cables and titanium rods as controversial. Hanetal detected PGK to be higher in a shorter time in patients using the chrome cables rods compared to titanium rods. In the same study, they also experiences higher rates to breakage in titanium rods compared to chrome rods. Select UAV, despite the fact that there is no consensus in literature regarding the selection of the UAV. Kim et al. Reported UAV in the upper thoracic spine demonstrated a high rate of PGK compared to UAV in the lower thoracic spine or upper lumbar spine. And they say in same chapter, for 55 years and older, they didn't find a significant difference between the upper thoracic UIV or lower thoracic and upper lumbar. Boachi says no difference in the rate of PGK in the adult idiopathic scoliosis population with UIV T6 or above and those with below UIV T6. It is also proved that choosing a UIV at T8 and below may cause PGK. This is a case operated for a 16-year-old boy operated for Scheuermann kyphosis. After 3 months, PGK developed progressive over the time. We revisited several times. PGK development become easier when the instrument level is not chosen well, especially for Scheuermann kyphosis. And unfortunately, in the end, the instrument had to be extended to cervical vertebra. Is PGK deformity recurrence and or natural aging? This is an important question because radiologic findings in PGK are similar to natural aging process, including osteopenia, facet joint degeneration, discrete loss, wedge compression deformity in the spine. And the underlying event of the PGF is often an acute structural event in the early postoperative period. Most common causes of PGF are fracture and soft tissue damage. Patient core studies say to us 7% had trauma and 7% had implant pull out in PGF. There are some classification for PGK. Yagi et al. Classified the PGK for type, grade, and spondylolisthesis for spondylolisthesis. This classification gives an idea for PGK. It does not provide any guidance for the management of PGK as well. And Heart International Spinal Group organized the new scale for PGK, including the neurological deficit, focal pain, instrumentation problem, change in kyphosis, UIV, level of the UIV. Recommended the revision surgery for those with a total score 7 or above. Lafarge et al. Designed the new scoring system for PGK. They detected PGK rate B for 17% for 1 point, 69% for 5 point. Their scoring system, including the upper instrumented vertebra, lordosis change, lower instrumented vertebra, and age. How can we protect our patient with from the PGK? We have as a modifiable risk factor fusion level to a baseline kyphosis angle, instrument stiffness, composite metals, use of implants, distal osteotomies, soft tissue, less soft tissue damage in UIV. Optimal sagittal balance using a transient rod might reduce the risk of PGK. A good evaluation is, of course, the most important step when evaluating a patient, including the comprehensive neurological examination, inspection, palpation for UIV, screen infection, and whole spine radiological examination. Of course, we determine the bone mineral density for every patient. It may be logical option to leave the top of the UIV sleeve a little loose when tightening it. However, if it remains too loose here, revision may be needed for example, in this case. In flexible spinning, if global balance can be achieved without osteotomy, extension of the fusion is sufficient. In rigid or severe kyphosis, maybe need Schwab 2 or 1 or 2 osteotomy. And in case of rigid kyphosis and anterior column compression, is it need the Schwab 3 osteotomies or another 4 or 5 osteotomies. The use of anterior interbody should be considered when significant anterior column defect is present for greater sagittal alignment correction. This is an cases 13 years old male. He has neurofibromatosis 1, operated for diastometamegalia in 5 years old. Operated with traditional growing rod and magic rod. His operation started 6 years old. Unplanned instrumentation revision. He has unplanned instrumentation revision 2 times for infection. Magic rod operation, operation is started with magic rod operation in 6 years old. After the operation, he has 2 revision surgery for infection. After revision surgery, operated with traditional growing rod, but traditional growth rod is broken in here. 3 months after operation, and late operation, they changed the traditional growing growth technique only unilateral techniques. 3 months late after last operation, and later 6 months after last operation, he has a proximal junctional failure. This is an Sanders and classification, hyperextension, rotor, and hyperflexion graphy. Some secretions were not properly not good insertion. Some secretions, for example, T7, T5. The patient developed, he had drop syndrome and had to carry it with his hand. In this patient, we first removed the problematic screws and rows. Then we applied the holographic traction for 4 weeks. We reached the appropriate cup angle in 4 weeks. Holographic traction also helps to correct in the sagittal plan. This is first erect. This is 1 year later X-rays. This is clinical pictures for these patients. Another case is operated T3 compression and T burst fractures with C2 between the T7 pedicular instrumentation and lateral mass secret instrumentation. 4 months ago, he has iatrogenic traumatic kyphosis. He was in intensive care for a long time due to subarachnoidal hemorrhagia. His gap score is very worse, and his secret is pull out, and T4 secretes placement is not very well for these patients. We operated these patients with corpectomy and posterior instrumentation with between the C7 and L3. This is the pictures 2 years later. Another case is 17 years old female. He has operated for kyphosis scoliosis 4 times. She has low back pain. She has back pain and Sanders 8, Richter 4, and closed radiate cartilage. But we have not X-rays for index surgery because she has operated another center. But we can see in post-op film shows that the lumbar lordus is completely disrupted in here. The patient's lumbar system was then removed and thoracic region was instrumented for kyphosis in same centers. Then within 6 months, sagittal and coronal alignment got worse. This is a coronal alignment, and this is an kyphosis between the 87 degree. It is necessary to make a good planning to choose where to perform osteotomy and appropriate road contour. This is a perfect. This is a 1 year later X-rays. This is a pictures for patient 1 year later. Thanks for your chance speaking.
Thank you very much, Ercan, for this pretty complex lecture. There is a lot of information which probably we would need much more time to really go into the details. Is there any questions from the audience? Questions? Any comment from Claudio, maybe? Yes.
Actually, we should to differentiate PJK or PJF in adult deformity or in elderly, PJK in pediatric subject are two totally different topic. Max, you are right. Is a huge topic. It's quite impossible to cover it. But anyway, speaking about just in order to focus on only one point, speaking about the Schoerman image to have to treat a patient with 60 degree of pelvic incidence. Ideally, if your subject has 60 degree of pelvic incidence, the ideal lordosis should be more or less 60 degree. Suppose that you correct the kyphosis, the hyperkyphosis, to 40 degree, for instance. In this case, you create a compensatory lumbar lordosis close to 40. You will have a inverted mismatch between the lumbar lordosis and the pelvic incidence. In my experience, this is the main reason why sometimes, not every times, in Schoerman we develop PJK, just because we create this kind of new, let me simplify, sagittal malalignment. What do you think about this?
You have to put on the microphone. The microphone.
Ercan, you must unmute yourself. Yes, now it is.
Okay. Scheuermann kyphosis is most complex spinal deformity, I think, because Scheuermann kyphosis, in Scheuermann kyphosis, we correct only thoracic kyphosis, but balances is changes with lumbar lordosis and cervical lordosis, because we cannot reach the ideal alignment for Scheuermann kyphosis every time. PGK is higher, or PGF is higher in Scheuermann kyphosis. I think this is the main point in here. We cannot elevate the lumbar lordosis and cervical lordosis with posterior instrumentation system, because this is a complex balance in here for Scheuermann kyphosis.
Maybe Claudio may answer here, but in fact, in my experience, it depends at which age you operate these patients. You know, when you operate these patients in adolescence, that means around or shortly after the puberty, then I think that the upper thoracic spine and the cervical spine, as well as the lumbar spine, they have the potential to compensate when you do the correction in the thoracic, in the main part of the deformity, as when you go with older patients where you don't have this compensation power, then it becomes very complex. Then you may end up not only with an upper deficiency in the upper spine, also in a distal junctional kyphosis. What does not happen when you, usually not, at least I haven't seen that, in patients which are young enough to have still the power of compensation. But once they are adult and there is already some degeneration, then we are dealing with this significant problem. That's my personal experience with that. I don't know what Claudio thinks, but...
Maybe another factor is aging is important for Scheuermann kyphosis. We can relate the aging for Scheuermann kyphosis with Sanders or Risser or Menashe, but aging is important point in here, I think.
Yes. I think, you know, I was quite surprised to hear that the junctional kyphosis in the upper thoracic spine is more rare than in the lower thoracic spine. And then, you know, you mentioned the paper from New York where they wrote about this in so-called adult idiopathic scoliosis. You know, the problem is that many of these people, when you look at these cases, what they have, these are not either adult idiopathic scoliosis. These are, in fact, de novo scoliosis, or the other way around. So I think we have to be very precise with this kind of formulation, because we are comparing apple with pears. You know, this is very clear. An adult idiopathic scoliosis has a complete different behavior from an adult de novo scoliosis. In fact, they behave very similar, like the adolescent idiopathic scoliosis, at least when they are in the middle age, between 20 and 45 or something like that. So I think we have to be very careful with these statements in the literature, which is based on a patient collective, which is not really a uniform patient collective, but a mixed one. I don't know what you think, Richard and Claudio, about this, but this is my experience when I study these papers, and I have unfortunately to study a lot of them when I was editing a journal. You know.
If may I have a comment about this very, very hot topic? We should to consider also the cervical spine. the cervical spine is strongly correlated to T1 slope. If this slope is very low, your patient has to force in kyphosis because the daily life is in kyphosis, in cervical kyphosis, because you have to read, you have to eat. Your cervical spine must be in kyphosis. If your slope is too low, the risk of develop PJK is significantly higher. That means we have to pay attention not only in thoracic area or in lumbar area, but we have to start to evaluate what happened in the cranial part of a thoracic spine and in cervical spine. Another very interesting element for evaluating the risk in immediate post-op, the risk to develop a PJK is to measure in sitting position the distance between the C7 plumb line and the upper instrumented vertebra. If this distance is more than 11 centimeters, the risk of PJK is huge. If it's less, the risk is significantly less. But you have to ask a sitting X-ray. If you have a EOS, is easy. In other way, it's not so easy. But there is a huge topic, a huge field in which our knowledge is not so deep as our patient needs.
Yeah, I think you're absolutely right. Our knowledge is very mixed. You know, it's not like in exact science where you have a clear arrangements in an experimental setup. We are dealing basically, as we have seen now, again in these lectures, we are dealing very much with cases. So our surgery is very much a narrative science, case-based, and sometimes even we think that we have found a law or a principle, then very soon you will find a patient who doesn't fit in this system, you know. So we have to be very careful with our conclusions from individual cases, and that's the big problem in all these publications, because we have not really a standardized way how we can analyze and how we can evaluate these cases, because it's mostly not prospective, but it's after it has happened. And this is, you can see in these publications, you know, somebody says this is a high risk for an adjacent segment problem, and the other one says no, this is not the problem. It is depending always from cases and how you define these cases. So we have to be very careful with these conclusions on principles of the spine. The spine is a very, very complex living structure. Any other questions?
I think there is one question from Fatih Hadidi telling that should we undercorrect the kyphosis to avoid PJK in Scheuermann kyphosis? Undercorrect.
Yes. I think balance is whole, and we cannot reach a result by changing one place in Scheuermann kyphosis. That's why we should avoid overcorrection for PGK. Overcorrection is a big problem for Scheuermann kyphosis and other kyphosis problems.
Yes, okay. So I think we are pretty much through in time, a little bit longer, but very interesting discussions and excellent presentations. Thank you very much to the lectures. I think it's really worth to review this lectures when you are really interested in this topic. And I leave it to Mehmet Zileli to make a final statement and to close this session. Thank you very much.
Thank you, Professor Aibi, and thank you all the speakers, Claudio, Ercan, and
Richard.
for very nice lectures. And also I thank all the participants. Okay, goodbye. Good night.
Good night.